Hello, Doc. Please, we can start.
Okay, all right. So we will continue from where we ended last week. That was acute asthma management. So today we'll focus on chronic management of asthma. So before we start, let's look at these few definitions. At times you will hear about inhalational corticosteroids. When it comes to the chronic management of asthma, these agents are key, backbone of chronic asthma management, and they use a whole lot of things: standard dose, high dose, depending on the patient and the severity of the asthma. And therefore, when it comes to these definitions, it's different for different agents that are used as inhalation. So, for example, when we are talking about standard dose inhalational corticosteroid, if you take agents like beclomethasone and budesonide, these two, in adults and children who are older than 12 years, standard dose budesonide and beclomethasone is 200 to 800 micrograms per day. So when you are 12 years and above.
So, Dr.
Yeah, hello?
Please, can we do a brief recap of what we did last week? I'm just begging if you can.
Can you take us through? Were you part of the class?
Yes, I was.
Okay, so can you take us through the acute management of asthma?
Honestly, Dr. I'm not sure though.
Why? But you were not part of the class?
Yeah, I was.
So you have forgotten everything, all the things that we discussed under acute asthma?
Well, not necessarily everything. I just felt that probably if you do a little recap, it will make going forward very easy.
Tell us what you remember.
Hey, Doc, please, let's go on.
Class captain, can you please tell us something, at least, what we did last week?
Okay, so last week, we started from the definition of asthma. We spoke about the types, that's the intrinsic and extrinsic. And then we moved on to the investigations and diagnosis, the symptoms, the lung function tests. And then we looked at the drugs used in the acute management. So we spoke about oxygen and how most of the time we forget that oxygen is also used, but it's very important in the acute management. Then we spoke about the short-acting beta-2 agonists. So we spoke about salbutamol, which is nebulized, and then terbutaline. And then we also spoke about oral prednisolone, and then other alternatives that can be used in its place. We spoke about IV hydrocortisone and then methylprednisolone. And then we spoke about ipratropium bromide, which is a short-acting anti-muscarinic agent. And then we spoke about IV magnesium sulfate. We spoke about aminophylline. And then for the aminophylline, Doc was emphasizing on the fact that it has a short therapeutic window, as in it's narrow. So we spoke about the 10 to 20 milligram per liter and how if it's above 20, you start seeing signs of toxicity. I mean, if you give a dose above 20 milligram per liter, if there's 20 milligram per liter found in the plasma, you start seeing signs of toxicity such as arrhythmias, etc. If it's below 10, there'll be no therapeutic effect seen. And then we spoke about factors affecting the clearance. So conditions and drugs that can increase or decrease the clearance. So that's how we ended, basically.
All right, thank you. Thank you. So basically, that is a very good summary of the whole discussion we had on last week. Don't also forget the possible trigger factors so that you can stay away from them and then modify those that are modifiable. Thank you very much. I hope it's okay. The one who asked the question, I hope it's okay.
Yeah, she has done a good job.
All right. Thank you. Okay, so quickly, when we say standard dose beclometasone or budesonide, these inhalational corticosteroids, the regimen is such that you have to take the total dose for the day, divide into 2, and take them morning and evening time. So it's always on BD basis. These are preventers, and they are not used when you have the attack. They are rather used to prevent the onset of an attack, and they are always used on daily basis. BD, that is the regimen. So you have to know the total daily dose. So beclometasone, budesonide, standard dose in those who are 12 years or above is 200 micrograms to 800 micrograms per day. So if you are on beclometasone or budesonide and you are within a range of 200 to 800 micrograms per day, which you divide into 2, you don't take the total daily dose at once or TID. The total daily dose is taken in 2 divided doses. So if you're on 200 micrograms, it qualifies to be termed as standard dose budesonide or beclometasone. But you are going to divide the 200 into 2 and inhale it at 100 micrograms BD. Likewise, if you're on 800, it also qualifies as standard dose beclometasone or budesonide. Divide into 2, so that will be 400 micrograms BD. All inhalational corticosteroids are preventers, and they are supposed to be inhaled on BD basis. Divide the total daily dose into 2 and take it as BD. Those who are between 5 and 12 years, their standard dose beclometasone or budesonide is slightly lower, especially the upper limit. So if they are between 200 up to 400, then in this category of patients, you can say that beclometasone or budesonide is being given at standard dose. How about fluticasone or mometasone? 100 to 400 micrograms for 12 years and above, and 100 to 200 for those between 5 to 12 years. These doses for these different agents are what we describe as standard dose ICS. So it depends on the agents you are using and the age of the individual. That will determine what standard dose of this ICS means. How about high dose? When do we say that we are using an inhalational corticosteroid in high doses? Again, for budesonide and beclometasone, high dose means high doses. So if you are taking something that is greater than the upper limit of the standard dose, so say from 800 all the way up to 2,000 micrograms per day, of course, in 2 divided doses. Then for children between 5 to 12 years, a maximum of 800 per day. That is the high dose budesonide beclometasone. For fluticasone and mometasone, up to 1,000 for 12 years and above, and up to 500. Obviously, the most common agent that we have in Ghana we have Seretide, and we have Symbicort. Seretide contains fluticasone, while Symbicort contains budesonide. So at least if you can't remember that of beclomethasone or mometasone, make sure that you remember budesonide and fluticasone. And obviously, if you know the one for budesonide, automatically it's the same for beclomethasone. And if you know the one for fluticasone, it's the same thing for mometasone. All right, so that is the doses, the ranges that you can describe as either standard or high dose. It depends on the agent in question and the age of the patient. Always remember that ICS are taken on BD basis. Pick the total daily dose, which should be micrograms. You divide the total daily dose into 2. Take it on BD basis every day. So it is daily because you are using it to prevent the onset of an acute attack. And therefore, it's supposed to be taken every day on BD basis to prevent the onset of any possible attack. Now, let's look at how the guidelines are recommending when it comes to the management of chronic asthma. Again, the management has been grouped into 3. Those who are 12 years and above, between 5 to 12 years, and below 5 years. Depending on your age, we have different recommendations. And always they recommend first line, that in asthma, they refer to it as track 1. So first line recommendations, track 1. Then alternatives will be track and maybe others. Within each track, they start you from different steps. So you start from step 1. And if step 1 is not able to manage or control your chronic asthma, and you tend to have breakthrough attacks frequently, they graduate you to step 2, step 3, step 4, and depending on your age, you may even go to step 5. So within each track, there are steps. If you are lucky enough and only step 1 within a track is able to manage you, then of course you have the best control. If the step 1, which comes with lower doses of agents and even fewer agents that you use, is not able to control, then they grade you up or they promote you to the next step. Where will be used.
Hello,
Remember, hello?
Please, your line is breaking.
Okay. Is it better? Is it better now?
Yes, please.
All right. So within each track, there are steps. So in the beginning, or depending on the severity of your asthma, you could be started on step 1. But track 1 is always first line recommendations. All things being equal, if you have access to the medicines, you are not contraindicated to any of the agents. You have to go by track 1 because the evidence available is in favor of always the track 1 recommendations. But in each track, there are steps that, depending on the severity of your chronic asthma, they will start you on. So if you don't have so many complications, they could start you on track 1, step 1. If step 1 agent, obviously with fewer drugs at lower doses, are able to control your asthma, fair deal. If not, then within the same track, you will be graduated to the next step, which will be step 2. As you go higher the steps, what happens is that additional agents will be added since the lower steps are not able to control, or it could maintain the same agent but increase the doses. So the problem is that as you add more agents by going up the steps, or you increase doses, because the patient is not well controlled under the lower steps, you are also exposing the patient to the various side effects of the medicines. So the hope is that within each track, the lower steps will be able to control, because the lower steps come with fewer number of agents at relatively lower doses, so that you have minimal exposure to side effects of fewer drugs that are used within the lower steps. So let's look at what goes on when it comes to adults and adolescents who are 12 years or above. So 12 years and above, what do we do? So now, so it's this same thing. You have the assessment and everything and the various steps that are broken it down into various slides. So we are looking at when the patient comes, or at every opportunity that you get to meet the patient, you need to assess the patient, do your reviews, and do your adjustments if necessary. So let's look at how you go about it. So remember, we are on 12 years and above. 12 years and above. So you need to always assess. And remember, it's about individualization of therapy. You don't generalize treatment as we always recommend. So in assessment, how do you do? What are some of the things that you do when it comes to assessment? In some patients, it may even be their first time of attending to the asthma clinic. You may have to confirm the diagnosis of asthma. It may not be necessarily asthma, so that you don't put the patient on any anti-asthmatics unnecessarily. So you confirm the diagnosis if it is very necessary to do so. Then, of course, as part of the assessment, you try and identify possible risk factors. Are there any comorbidities that may contribute to the severity of the disease? If the patient is already known asthmatic and has been offered inhalational therapy, as the person knows his or her inhaler techniques, and obviously what is the level of adherence. This step or this assessment is very key when it comes to the success of asthma management. Inhaler technique is very, very important. We take things for granted and we think that, oh, patient A has been a known asthmatic for about 10 years. We always dispense this kind of inhaler to him or her, and therefore the person knows how to use it. The evidence available has it that almost 50% of asthma patients don't know how to use their inhalers appropriately. And that is the main cause of the patient not being able to control his or her asthma. Therefore, at every opportunity, you need to assess inhaler technique and, of course, adherence. Then, if the adherence will occur, obviously, you need to assess or take into consideration the patient's preferences as against the patient's goals, the patient's expectations. So these are some of the things that you do under assessment. Of course, you have to review the patient's symptoms. Are there improving symptoms or worsening symptoms? Are there breakthrough attacks, exacerbations? How about the side effects of the medicines? This is also important, because in every management, if you are going to use any drug, one of the key goals should be how are you going to minimize, or if possible, avoid the side effect. How is the level of the patient's lung functions, and is the patient satisfied based on the current management? Do all these reviews and assessment, and if there is the need to adjust, what are some of the things that you do? Can you tackle some of the modifiable risk factors as per your assessment, because you look out for possible risk factors. Can you look at them and adjust to help the patient, as well as the comorbidities? Can you push in non-pharmacological strategies to help the patients? And the asthma medications. Is the patient stable at this time? Or the condition, is it getting worse? And therefore, does it demand that you need a downward or upward adjustment? If it's getting worse, as I said, you move the patient up the steps. And therefore, one of the strategies is to either add on or the same drug that the patient is on, you increase the doses. Is it possible? If the patient has also been stable for about 3 months or more in asthma, you have to decide to step the patient down, because as you give high doses, you are exposing the patient to the side effect of the medicine. So within track 1, for example, if the patient has been stable on, say, step 4 for almost 3 months, then at 3 months, you could decide to analyze and then step the patient down to track 3, because obviously track 4 will have more drugs at higher doses, predisposing the patient to side effects as compared to track 3. Can you do that? How are you going to do it? When are you going to do the step down so that the person will not get a breakthrough attack? All these things you have to do. And obviously, education is very important. You need to educate the patient well, as per the drugs, as per the conditions, as per the trigger factors. So these are the first things that you need to do. And these are very, very important before you even initiate your recommended tracks. Any queries? Last captain.
No, please.
All right. So now let's look at for 12 years and above, what is the recommended first line, also termed as track 1. So for track 1, you are looking at controllers and the preferred or the recommended reliever. Remember that we are doing chronic asthma management, but in asthma, there is always a threat of a breakthrough attack. Though one of your main aims is to put the patient on medicines and prevent such exacerbations. But you never know when the patient may get exposed to a very stubborn trigger factor that can still overcome your preventer therapy. And therefore, as always, as you give the patient drugs for chronic management, you have to protect the person and guard the patient against possible breakthrough attacks. So that should, in case the attack happens, the patient will have relievers available to deal with the initial stages of the acute attack, so that it doesn't worsen and move up the ladder from moderate to severe to life-threatening and near fatal. So as always, as you give your medications for chronic management, you give the person something to protect him or herself should, in case there is a breakthrough attack. Obviously, most drugs for chronic management don't have quick onset of action, and therefore they can't be used against breakthrough acute attacks. That is why, in most cases, you have to give additional agents as relievers, so that should, in case there is a breakthrough attack, and the person will use it. But as we discussed the other day, there are some agents that can be used for both chronic, that is preventer therapy, and because of their pharmacokinetics, they also have quicker onset of action. They don't only have longer duration of action, but they also have quicker onset of action. And this agent can be used, therefore, for both preventer therapy and reliever therapy. Typical agents that can be used for both is formoterol. Formoterol. So formoterol has a longer duration of action. It can cover at least up to 12 hours as a bronchodilator. And because of its longer duration of action, it qualifies to be used as a preventer therapy to provide bronchodilation. It also has a quicker onset of action, even better than that of salbutamol, 3 minutes approximately, and therefore combination of formoterol plus an inhalational corticosteroids. Typical in Ghana, we have Symbicort, that is budesonide, which is the inhalational corticosteroid, and formoterol, which is supposed to be a long-acting beta adrenoreceptor agent. But because of its kinetics, it has a quicker onset of action, and it also qualifies to be used as a reliever. So when you are using Symbicort, use reliever and preventer therapy. And therefore, you don't need to go and buy, say, another short-acting inhalational agent as your reliever. The most important thing is that if you use formoterol-based agent with an ICS as a reliever and at the same time as a controller, the evidence is that it reduces the risk of exacerbations as compared to using a typical short-acting inhalational agent such as salbutamol as a reliever. That is the evidence. So now it means that when you put somebody on ICS, say budesonide plus formoterol, that is it. The same drug will serve as the reliever therapy, so that should in case there is a breakthrough attack, you can use budesonide plus any ICS like Symbicort. And at the same time, that combination is qualified to be used for the chronic management. That is the preventer therapy. So what are they saying? Step 1 or 2, and the patient comes looking at the signs and symptoms to start from the lower steps. For track 1, that is first line therapy recommended. Since the patient's signs and symptoms are not that serious, you can start the ICS plus budesonide. Henceforth, I'm going to use Symbicort as an example. If I say Symbicort, then I'm talking about budesonide plus formoterol, because that is the most common one that we have. We also have Seretide, but Seretide doesn't have formoterol. It has salmeterol, but salmeterol doesn't have a quicker onset of action, and therefore it can be used as a reliever. It can only be used as a preventer therapy. So fluticasone and salmeterol, which is Seretide, can only be used for preventer therapy. And therefore, if that is the one you are using, then you will need another agent to be used for reliever, should in case there is a breakthrough attack. And therefore, Symbicort has this advantage over Seretide. So say Symbicort, since the patient's signs and symptoms are not that serious, you are going to use it on PRN basis. PRN basis. So PRN basis means that when the patient is in a bit of discomfort, the patient would inhale the Symbicort. It's not going to be on strictly BD basis per day. So step 1 and 2, as needed, low doses of ICS formoterol. So Symbicort as an example. If this strategy, you assess the patient, if possible, if you are not getting frequent breakthroughs, but you see that the patient is still not comfortable, up to 3 months maximum, and the patient is still not okay, or you are not meeting your goals of therapy, then you have to graduate the patient up the steps to say step 3. That will be, again, after you assessing the patient and doing the first things that we said. So you graduate the patient to step 3, where the patient will be taking low dose maintenance. Initially, it was as needed, PRN. But since the PRN is not helping, you are now changing the PRN to maintenance. And the maintenance is the BD regimen. BD regimen. Every day you are taking the drug morning and evening time, BD basis, which means because the same drug doubles as a reliever, you can't keep the inhaler in the house. You have to keep it with you wherever you go, because if you get any breakthrough attacks during the day, it should be with you so that you use it. If you are using Seretide, and let's say you buy salbutamol inhaler, which doesn't have a better advantage as compared to formoterol-based ICS, you keep the Seretide in the house because you are going to use it only in the morning and evening. So before you move out from the house, you inhale. You get back home after work, you inhale. But your salbutamol inhaler should be with you because it is meant for reliever therapy. You don't know when you are going to get the attack, though you are on a preventer therapy. But for Symbicort, it is the same drug that you are using for the two strategies, both as a reliever and as a preventer. So you can't keep it in the house. It should always be with you wherever you go. If you are not getting any breakthrough attacks, you do your usual BD. If it is BD, you do it. If it is PRN, when you are on step 1 to 2, you do your PRN. Okay. So step 3, same low dose, but at maintenance therapy. Maintenance therapy, again, is daily BD. If you are on this, again, maximum 3 months, and we are still not getting what we hope for, we are not getting to our target, then we graduate you again to step 4. As we move up the steps, remember, we are either increasing doses, adding additional drugs, or even the frequency becomes shorter. So step 4, you are moving from low dose to medium doses on maintenance therapy. So which means that we will increase the dose a bit to medium doses, again on maintenance therapy. If still at step 4 you are not doing well, then we graduate you to step 5. You see that at least step 5 we are doing add-ons, where, for example, could be added. But at step 4, when you are graduating to step 5, if you are not a respiratory specialist, you have to refer the case to a respiratory specialist who would actually manage the step 5. So the person will be doing tests, phenotypic tests for atopy and whatever. He's the specialist. The same person will try and consider high dose. So high dose combinations are prescribed by a respiratory specialist, not a GP. So here the person may even consider high maintenance dose ICS combination. The person may consider to add additional agents like anti-immunoglobulin E agent. Remember omalizumab. There is a table that talks about the newer agent. So as we go ahead, you'll meet that table. Or the person can even look at specific interleukins. So like the interleukin 5 and interleukin 4. We even currently have newer agent, thymic stromal lymphocytin agent. So agents that can interfere with specific anti or inflammatory mediators are all there. But remember, it is only the respiratory specialist who is allowed to do step 5, because step 5 is going to add several agents that they have the knowledge. A GP, since you are not a specialist in that field, you are not allowed. Drugs are limited to level of care. So depending on your level of care, you are allowed to prescribe up to a certain level. When you hit your limit, you refer the case to the specialist who is allowed to prescribe a specialist range of medicines because he has the knowledge and the know-how to control and manipulate those agents against the patient in question. Any question, class captain. So this is how you do, for example, the track one. Always remember that in chronic management, you should have a certain reliever on you. The best now is the same agent that can do the reliever and the preventer therapy. As you fail to perform or you fail to achieve your goals, we graduate the patient or we move the patient up the steps. As you move up the steps, all that we mean is that you are not improving, we are not getting our goals. So we are going to either increase the doses of the medicines or even add other agents to come in and augment the therapy so that we can have total control. One key thing when it comes to total control of asthma is the absence of exacerbations. Signs and symptoms are low. But always remember that the side effects of the medicines are there. And therefore, additional target, you don't do more than 2 night times within a week when you are on any step. And therefore, when you have this, then you'll be graduated. It means that you are not getting. Then, when it comes to daytime attacks, it depends on the goals that you set. So maybe 4 times within a week or 2 times within a week. But all things being equal, we don't want even any breakthrough attacks, provided the patient is able to stay away from trigger factors. The patient will quickly be graduated. And mind you, it is not always that you start the patient from step 1. If from the history, the level of acute attacks is nighttime attacks and how the disease is classified. We have persistent severe attacks, we have recurrent attacks, mild, persistent, those things, that table. I wish we can go back, but it's too far. So depending on that, you may even be started straight away from step 3. So let me see if we can. It's very far, but let's try and then. It was one of the classifications. So depending on that, you can even be initiated from step 3, step 2 of track 1. And then we start from there. Because if you start from step 1 and 2, yes. So you see, depending on maybe your history, if yours is, say, severe persistent straight away and you are getting daily breakthrough attacks, nighttime attacks are also frequent or mild persistent, demand that we even start you from step 3. So we know that if, let's say, we start you on step 1, we don't expect you to be continuously having intermittent attacks. If you still have intermittent attacks based on the frequency or the predicted FEV1 or the peak expiratory flow rates, then of course we will graduate you to the step 2 or step 3, step 4, because we want you to be kept there. If not, at least go back to symptom free. But if you are not being as in stable, then of course we can graduate you. And you don't necessarily need to wait until 3 months, because you may kill the patient by the time that the patient gets to 3 months. If you start the patient on, say, step 1 of track 1, and by 1 week you realize that the attacks has been frequent, then it means that obviously you don't need to wait all the way till 3 months before you assess. The 3 months is actually meant for those who have been stable all through for at least 3 months, and therefore you want to step down. But if you start somebody and within a week you realize that at the level that the person is even getting worse, moving from intermittent to mild persistent to moderate persistent, then quickly there is no need for you to wait anymore. You need to graduate the person up the steps to step 3, step 4. And if at step 4, the step 5. Please, are you okay?
I said, thank you.
All right. So,
Hello, Dr. Bobo.
Yeah, hello.
Yeah, so please, at presentation, how do we differentiate between breakthrough attack and acute asthma?
Oh, acute asthma is breakthrough attack. If somebody comes with signs and symptoms of acute attacks, we only term it breakthrough attack when somebody is on a preventer therapy that we don't expect any acute attack or exacerbations to occur. Yet, the trigger factor has been able to overwhelm our preventer therapy and there is an attack. That is when we say breakthrough attack. You are on a therapy, you don't expect to have any attack, yet there is an attack. That is breakthrough. But somebody who is not on any preventer therapy and the person gets an attack, since you are not preventing anything initially, you don't term it as breakthrough attack. You simply term it as an acute asthma. But if you say that you are doing a preventer therapy and still the person has experienced any acute attack, you just modify the name and term it as breakthrough acute attack. Are you okay? So both are acute attacks, but we add breakthrough when the person is on preventer therapy and it has failed, and the person is having an acute attack. Basically, they are both acute attacks. Are you okay?
Yes, please.
All right. So class captain, any further issues? If not, that is for those who are above 12 years. So 12 years all the way to adulthood, you go for this. Let's look at the other recommendations. So we move to track 2. So this is track 1. We are moving to track 2. So say second line recommendations. What are they saying? All right. So track 2. Oh, why is this thing misbehaving? Please, pardon me, I'm coming. The thing is freezing. Okay. So track 2. So track 2 is obviously an alternative to track 1. But the difference is that should in case you don't have a formoterol base combination, then you are going for the alternative. If you have a short-acting beta-receptor agent that you are going to use as a reliever, which obviously the level of evidence and the benefit is lower than when you are using a formoterol-based combination. But since you don't have the first track, you don't have, let's say, Symbicort, then your next option will be using salbutamol as a reliever, plus other inhalational corticosteroids in separate canisters. The advantage with the first track again is that you have just one canister to use. One canister as a reliever and a preventer. But the second track, obviously, you have a separate canister for the reliever therapy and a separate canister for the controller therapy. So let's look at what they are saying. So for that one, step 1, track 2, step 1, they advise that you take a separate inhalational ICS whenever you take your SABA, which means that it's on PRN basis. So whenever you are feeling uncomfortable, you inhale your short-acting beta-adenoreceptor agent. To make it simple, I'm going to use salbutamol to represent the SABA. the short-acting beta receptor agent, because that is the most commonly used agent in Ghana. So, for example, whenever you are feeling uncomfortable, you inhale your SABA. But whenever you inhale your SABA, remember to also inhale your inhalational corticosteroids. So you are using both on BD basis. The inconvenience is that you are going to use two separate inhalers, different one as the SABA and a different one as the ICS. It makes the regimen cumbersome. Obviously, using one canister versus using two canisters, the one canister is more convenient. The worst thing is that the inhalational corticosteroids, the makeup may even be different from that of the SABA. So you may have the ICS as a tubohaler, whilst the SABA will be a metered dose inhaler, which means you have to learn the inhaler techniques for both, because they are different machines, they are different agents that you are using, and the inhaler techniques may differ. Even the single inhaler technique, individuals find it difficult to do, as compared to now you are using different machines with different inhaler techniques. So it even worsens the condition. It makes how to achieve your target very difficult. Again, if you are on step 1 and you are not getting enough benefits, you'll be graduated to step 2. At this point, you move away from the PRN and go by maintenance doses. So the difference is maintenance doses, but you are still using low doses. As step 2 fails to help you, then we change from the SABA. We change from the SABA for reliever and the maintenance dose ICS to now a combination of a low dose maintenance therapy of an ICS and a long-acting beta adrenoceptor agonist. So, for example, we now switch to salmeterol and beclomitasone, or salmeterol and fluticasone. So you go at step 3. If still you assess and the patient is not benefiting enough, you go to step 4. At step 4, you change from low dose to medium or high dose. Medium or high dose, again, as maintenance therapy. Remember, the maintenance therapy is always BD for ICS LABA. At step 4, if still is not helping, refer the case to a respiratory specialist who will be doing additional agents, for example, adding a long-acting antimuscarinic agent, adding other anti-inflammatory agents, specific anti-immunoglobulin E, interleukin 5, and the rest. Always keep your SABA on you as a reliever. Always keep. So in this, when you are on, say, step 3, then you can keep your ICS LABA in the house. Since the wherever you go.
Sir,
Again,
please, your
you
line
never
is
know.
breaking.
Hello? Hello?
Yes, sir.
Yeah, okay. So I'm saying that here too, when you hit the step 4, keeping only your SABA on you. Wherever you go, it should be with you, whilst your ICS LABA is kept in the house, because it will be taken on BD basis. You take it in the morning, you drop it in the evening. When you come back, you take it. But your SABA, like salbutamol inhaler, should be on you wherever you go. 4 possible breakthrough attacks when you are on your usual rounds. Then there is a last alternative for those 12 years and above. So
Sir,
we can have, Yeah, hello.
Before I continue, I want to clarify something. So, for patients on step 3 and then step 4, that means that they have the ICS SABA, and the SABA there is used as a reliever. But in addition, they also have the LABA there for the
Hello.
chronic maintenance. Hello, sir.
Yeah.
Sir, please can you hear me? Hello.
Please repeat your question.
Okay, so I just wanted
Yeah,
to
hello. I can hear you.
clarify
Repeat your. Can you?
that for step 3 and 4, doesn't mean that they have the ICS SABA, that where the SABA is being used as the reliever, but in addition, they also have the LABA for the maintenance therapy. That's the
Yes.
preventer.
Yes. So normally these agents are like a combination therapy in one canister. So for example, serotype. So the patient at step 3 will be on maintenance dose serotype, which is salmeterol and then fluticasone. So that is what the patient will be using every day, BD, for preventer therapy. But you should be on guard. You should guard yourself because you can still have a breakthrough attack. So the patient will always keep salbutamol inhaler in the bag so that even on the preventer therapy, if the person exposed or is being exposed to any trigger factor that can cause breakthrough attack, the person will be able to use the salbutamol as an example of SABA to address the breakthrough attack. Are you okay?
Yes, sir. Thank you.
Okay. So the good thing,
Please,
So please, I have a question.
with regards
the good thing is that if you are on mental, yeah, I'm coming. Let me land. Then you ask your question. The good thing, one of the good markers is that you would be happy if somebody on ICS LABA plus a reliever salbutamol, the person keeps the salbutamol and then it get to expiry. The salbutamol get to expiry. It means that the preventer therapy has been able to control the attack. And of course, the person has not been having breakthrough attacks. So one of the targets is to always have the salbutamol inhaler expiring on you. If you keep on using it, then it means that the preventer therapy is not working. And therefore, that alone may call for your graduation to a higher step. Okay, so now please ask your question.
Please, with regards to the 2 tracks we reviewed so far,
Hello?
the patients to management via track 2, considering the fact that we tracked.
Come again.
I was asking that with regards to the 2 tracks we reviewed so far, why would a patient be subjected to therapy under track 2 when track 1 seems more convenient? Are there special reasons why a patient will be managed?
No. Remember, I've been saying that track 1 is first line. Are you okay?
Okay. Yes, please. Okay. Yes, sir. Thank you.
So you always opt for first line. Yes. Unless there are some reasons why you can't do first line, then you go to second line. So track 1 is like first line. Track 2 is like second line. Okay. Any other question? Hello?
Hi, please. The step
Yeah,
for
I heard.
track 2. Oh, okay.
I heard the mail voice. Okay, you ask your question. If maybe it's not ready when it comes back. So ask your question. If you have a question, ask it.
Yeah, so please,
Hello?
I didn't hear much. Hello. Please, I didn't hear much about track 2, step 2, the one with the low dose maintenance ICS. So if the
So that
person
one,
is, yes.
so that one, you are only using ICS. You won't add any LABA to it. So if you are on step 1, it is ICS separate in one canister. one inhaler. You inhale it whenever you inhale your SABA, which means you only inhale your SABA if you are not that convenient, if you are not feeling comfortable. So you feel like you are getting some discomfort, you inhale. But whenever you inhale your SABA, make sure that you inhale your ICS. So it means you are doing the ICS on PRN basis. On PRN basis. And if this step 1 strategy is not helping, is not controlling, then you move up to step 2. So at step 2, you are not going to do PRN SABA plus PRN ICS. You are doing a low dose maintenance. So here, all the time, only ICS, if it is, say, fluticasone or beclometasone or budesonide, you are doing it at low dose, but on BD basis every day. There is no room for PRN now because the PRN did not help in step 1. Remember, in asthma, our most or the greatest problem is inflammation. So you make sure that you have total control of the inflammation by using the inhalational corticosteroids on BD basis, no more PRN, because the PRN has failed in step 1. Are you okay?
Yes, please. So for step 2, the ash thing, the one that's at the bottom of all the steps, the one that says reliever as needed, SABA, it doesn't apply to the step 2.
No. The reliever is always kept for breakthrough attacks.
Oh, okay. So the person can still keep the reliever.
Yes,
like,
because the
in the
reliever is
background.
meant for possible attacks. Do you get it?
Yes.
In the beginning, I said that in chronic asthma, you can always get a breakthrough attack. And therefore, there is always the need to prepare for it. So the person should always have a reliever therapy on him.
Yes, please.
Yeah, it is only when you are using formoterol budesonide that the same drug will serve as a reliever and a preventer. You get it? If you are using any other ICS combination with a beta adrenaline receptor agent, it's not formoterol, then you better get salbutamol on you. Not necessarily that you are always going to use it. That one is meant for what? Breakthrough attack. That is why I just said one of the key things we hope to achieve is that your salbutamol should expire on you.
Yes,
please. If it expires on you, then it means that you've not been getting breakthrough attacks. Then we'll be happy. Just that when it gets expired, you always need to go back and buy for replacement. So we hope that you always buy, you don't use it, and it expires. You buy, you don't use it, and it expires. That's a good sign. It tells us that you are doing well on preventer therapy. But when you come and you're always using salbutamol, later on, we will look at the impact of frequent use of salbutamol inhalers like SABA. It's directly proportional to negative outcomes in terms of deaths and those things. Very soon we will look at
Yes, please.
that. So if you use more reliever therapy, use more the more you use preventers, relievers, then it relates to what? Poor outcomes. We don't want you to be using relievers frequently. It's a sign of poor control. Any other questions?
Thank you.
Okay. Any other? Class captain, can we continue?
Yes, please.
So other controller options, if you are not using track 1, track 2, let's look at other controller options. The only bad thing is that with these recommendations, we have limited evidence when it comes to safety and efficacy. So we hope that we always get the chance to use track 1. If we can't use track 1, then at least track. Don't want to get to the other recommendations because we don't have enough evidence on those ones. So that one you start by using low dose ICS whenever you use your SABA or daily leukotriene receptor antagonists. Any examples, class captain? Leukotriene receptor antagonists?
Zafelucas, Montelukas.
Yes. So that will be your first recommendations that you'll be taking. Just that on this agent, we have limited evidence. And then you can even add these house dust mite agents. So sublingual immunosuppressive therapy. Excuse me. If you are the type that you are exposed to house dust mite as a trigger factor, they can also consider giving you this type of agent. Unfortunately, evidence on efficacy and toxicity is limited. If you are on this step and you are not doing well, then they graduate you to medium dose ICS with the other recommendations repeating. Remember, you started with low dose ICS. It's not helping, you are moving to medium dose ICS. Then if it's not helping, you do add-ons. So you add a long-acting antimuscarinic agent like tiotropium, or you add a leukotriene receptor antagonist or this same agent. Then from here, if it's still not working, then you refer to a respiratory specialist who will be doing other add-ons, even including azithromycin. We even suspect that there is high possibility of infections as trigger factors, and therefore these specialists may try adding azithromycins. And the thing that we don't want to even engage ourselves in, oral corticosteroids. Oral corticosteroids as preventer therapy. We use oral corticosteroids as relievers during acute attacks. Very short duration, 5 days, maximum 1 week, we stop. But if we don't have any other options, for example, track 1 is nowhere to be found, track 2, then we are doing this final recommendations. And their first step, second step, third step is not working. Then, of course, you have to be graduated to that last step. And remember, the last option here is the addition of oral corticosteroids as preventer therapy. Why we don't want to see this oral agent is the numerous systemic side effects of corticosteroids, all the way from hyperglycemia and eventually DM, hypertension, striae, cataract, peptic ulcer, so many problems, immunocompromised state, and therefore a series of infections. And therefore, we don't want to get to the use of oral corticosteroids because we can't stand the numerous systemic side effects of long-term use oral corticosteroids. So these are the possible recommendations, track 1, track 2, and the third combination or the third recommendation for controller therapy. Any queries? So obviously, this third recommendation is not that good because they're already saying that even evidence on efficacy and safety is lacking, is limited. So why would you want to use a recommendation with such negative backings? No. You'd always want to go by first track. Thankfully, in Ghana, we have the chance to do track 1. Symbicort is even on the NHIS list. And therefore, you come and freely we give it to you. So in Ghana, we are doing track 1. And track 1 has a lot of benefits. Class captain, can we continue?
Yes, please.
All right. So now, so there is evidence against the use of SABA alone. Previously, the recommendation was that for the track 1, if you come and we see that your signs and symptoms are not that frequent, then they only give you a short-acting beta-adrenergic receptor agent, no ICS, no any corticosteroids. They only give you SABA to take home, and whenever you get this so-called infrequent attacks, you use your SABA, like salbutamol inhalers. And that recommendation was abolished. Remember, even when you are using a SABA, it is in track 2. It is recommended that you also inhale an ICS. The step 1 of track 2, you have to add an ICS. Because there was so many evidence against the use of SABA alone. Even in pharmacological terms, you realize that as you frequently stimulate beta receptors, then receptor insensitivities will occur, and therefore the drug may not even work anymore. So all in all, the evidence was that if you are always using frequently and therefore high doses of SABA, then it exposed the patient to high risk exacerbations. And it was detected that when ICS were added, it significantly reduced this risk of exacerbations. The worst thing is that those who use high levels of SABA, if, for example, within a year, you use more than 3 or even 3 canisters of SABA, then it was found to be associated with higher risk of emergency department presentations, which means the SABA alone wasn't able to control or prevent acute attacks. And therefore, if you are on SABA, you do get frequent attacks. And of course, that will send you frequently to the emergency department for acute asthma management. And the worst thing is that as you use it more, and those who were found to have used at least 12 canisters, it was found to be associated with higher risk of asthma-related deaths. So with this evidence, then the SABA alone regimen was abolished. And therefore, even in track 2, step 1, you saw whenever SABA is used, an ICS should also be inhaled. Step 1, track 2, even with that, that is the recommendation. Because adding ICS significantly reduces your risk of exacerbations. So now, there is nothing like you using only SABA. Even if you get just 1 attack every 5 years, when you come, we are not going to give you only SABA that, oh, yours is almost infrequent, so go and use only SABA. No, we will never give you only SABA. We give you SABA plus ICS. And even if you are going by track 2, whenever you inhale your SABA, please inhale your ICS in addition on PRN basis. Class captain, can we continue?
Yes, please.
Okay. So that, yeah, Helen.
So how about patients who keep going to the pharmacy to buy the salbutamol tablets?
Yes.
Like, what would you do in such a case?
I was going to wait and then ask you all these questions. Your Asthmanol and Asthmadrin and salbutamol, whether the guidelines recommend any of them. So that is the problem. That is the problem. Currently, you go through all the recommendations and you never find any of this. But in Ghana, we still have them on the market. And the problem is that when they come, it is you, the pharmacist, who also serve them. And it is you that you have stocked those medicines against experts' advice. So most of them, they don't even go to the hospital at all. And most of them do have their religious beliefs. Some of the challenges that the moment they accept to use the inhaler, then that is the end. They don't even appreciate that the disease is already a chronic one. They think that it will go at some point. And therefore, if they accept the use of any of the inhalers, then it will be there forever. But that is the case. So you, the pharmacist, let's go through the recommendations and see if we are going to meet any salbutamol tablets or any asthma or any asthma drug. Yeah, hello?
Sorry, please, before we proceed, with regards to the salbutamol tablet, where I am, there has once been an incident where a patient doesn't meet the criteria to be diagnosed of asthma. So it's more like classified as an allergic reaction by the MO. But then when she's exposed to some triggers such as cold weather, so she was placed on an antihistamine. But in this case, the antihistamines no more work for her. And she also isn't diagnosed of asthma. So in her case, wouldn't it be appropriate to give her salbutamol tablets? Because it's
So
breathing difficulty she has.
that is why I'm saying that if it's asthma, your MO, I don't know whether he's a respiratory specialist or not. So that's the problem. If you are not able to diagnose, it doesn't mean that the patient, you have ruled out asthma. You are not the specialist in that field. So once the patient displays some signs and symptoms that relates to asthma, and you are not sure, that's why we have what? Specialists in every field. You have to refer the case. You don't have to conclude and close the case like the person is not asthmatic. For example, if the person is not asthmatic, why is the person hypersensitive to some trigger factors like cold air? So maybe you are not able to diagnose the thing. Refer the case to a respiratory specialist for the person to take charge. Because the person obviously knows better than you when it comes to asthma. Maybe you also have your own field. You have your limit up to a certain level. So if you are not finding as in it's easy, once you know that there is a trigger factor, cold air, and the person is showing signs and symptoms of asthma, but you are unable to confirm, it doesn't mean that you should close it and give. Because the experts, like these general guidelines, if we go through up to the end, you are not going to meet any salbutamol tablet currently. You are not going to meet any asthma and asthma, the combination of theophylline and this the CNS acting depressant. No. So why do them? If you do them, you are going against guidelines recommendations, and it will be on you to defend yourself, especially when you are not an expert in that field. You don't conclude. It means you are not on top of issues, and therefore, simply you should refer to somebody who is a specialist in that field to control. Are you okay?
Yes, sir. Thank you.
Right. All right. So quickly, let's go through some few changes that the General 2022 guidelines added as against the previous ones. Very brief. So they say that if somebody comes, let's say an adult comes with an asthma and there is a breakthrough attack, you have managed the thing and now the patient is stable. As part of the additional investigations, you have to screen the patient on certain specific things. For example, somebody who has been on oral corticosteroids, or even high-dose inhalational corticosteroids, you have to investigate for the possibility of adrenal insufficiencies. Class captain, can you as in explain why the need for screening tests for adrenal insufficiency for somebody on maintenance dose of OCS or high dose ICS?
Please, can I call someone to help?
Oh, sure. If you are on, anybody. If I mention your name, doesn't mean that it's always you. You can always, as in, call somebody to help.
Yes, please. Frank, could you kindly help us?
So anybody, why the need to do this test? Why is it that they are recommending this if you are on ICS?
All right. So for patients
or you are on long-term maintenance dose oral corticosteroids, they recommend that kindly you screen or consider screening the patient. Hello?
Yes, doc. For patients taking exogenous steroids, there is the likelihood of adrenal suppression.
Yes, you are done. You are done. So that is it. That is it. You are done. So once you are bringing in exogenous steroids, there is always the tendency to suppress the adrenal gland because you have taken over the work of the adrenal gland. Adrenal cortex, for example, is supposed to release cortisol, and you are always bringing in exogenous cortisol. Any organ that fails to work, you've taken over my work, I'll relax, and eventually you get adrenal suppression. The gland will atrophy, and therefore there is the need to always screen the patient for this and try to adjust your doses. Again, they also recommend that, of course, we are saying that eosinophils are part of asthma issues. So patients who are having eosinophilia or eosinophils greater than 300 eosinophils per microliter, you have to always investigate for additional causes of eosinophilia. We know that asthma will cause increase in eosinophils, but if it is at this level, greater than or equal to 300, there could also be other co-founding factors, for example, like strongyloids infections. And therefore, you need to investigate. Don't take it like your management is not on point, and therefore, quickly you conclude that you are adding a biological agent. You know, biological agents do have excessive side effects. So consider checking for some of these kind of issues. They could be the cause of the increase in eosinophils before you consider going straightly for biological agents that are very potent but also toxic. If some of these things are there, then you manage, and that will not call for the need to use a biologic agent. You could also have agents with even hyper eosinophilia, those that comes with very high levels of eosinophils, 1,500, 1,500 and above. So in these individuals, you also have to test for the presence of conditions like eosinophilic granulomatosis with polyangiitis. This is what they are. Hello? Please. Hello? Hello?
Hello. Hi.
Hello? Okay. All right. So they also recommend that you also assess for phenotypes, those who do have excessive inflammations. Of course, we say that asthma, the underlying issue is inflammation. So those who comes with the atopy type with excessive inflammation, they are going to have increased or excessive fractional exhaled nitric oxide. That is one of the marker of excessive inflammation, or they will have excessive levels of eosinophils. They expect that you will test for this. One of the things that can interfere with this lab is when you are on high doses of corticosteroids. Because it will suppress the production of these markers of inflammation. Or you do it when the person is not on corticosteroids at all. Because if the patient is on corticosteroids, it could mask these markers because it will suppress the high level of inflammation, and therefore test for phenotypes for inflammation when the patient is on very low doses of steroids. The patient, we can know if he is one of these types or not. Then treatment options for patients with no evidence of type 2 inflammation on repeated testing. So you consider add-on. So it's like when you are using the third options. So those that you don't have excessive inflammation, consider adding other agents like LAMA to help increase bronchodilatations. And then The last thing, you consider using oral corticosteroids only when you have tried all your options. So oral corticosteroid is the last thing to consider because of the numerous side effects. Don't go there straight away. Unfortunately, in Ghana, that is what we do. You are at the pharmacy and somebody who is not on even any of the inhalational corticosteroids, the person is not on any of the recommended agents, will come and say, P. P is prednisolone. You don't know who introduced this person to prednisolone, but the person will come and then say P, which means he himself has graduated himself to step 5. And all the time he's on oral corticosteroids in prednisolone. These agents, obviously, we all know that they have a lot of side effects. And therefore, the best thing is to try and stay away from them. You only consider them when you have tried all your options and you are still not getting any results. And therefore, by weighing the benefit against the risk, because asthma will kill the patient, you realize that at this point, okay, let me go in and then you introduce. If not, reserve it as the last line of defense because it comes with excessive side effects. So now currently in Ghana, I'm not sure if we have the chance to do this biological agent, but elsewhere, should the need be, normally the respiratory specialist at step 5 of track 1 and 2 will start introducing some of these agents. So as I said, this is the table I was talking about. So for anti-immunoglobulin E, you can use omalizumab to control, and then the interleukins, the 5 agent and the receptor against the interleukin 5, the agent against the receptor of interleukin 5, and the last agent, the thymic stroma lymphopoietin antagonist. All of these are available, and according to the age groupings, you may or may not qualify. Some of them you have to be at least at age 6 before you qualify, others 18 years, 12 years. So these are also available there, but they are also reserved for step 5 of track 1 and track 2. And depending on your age, you may not even qualify to use some of these agents. Class captain, any queries?
No,
Any queries? All right. So for MCQ purposes, you never know. You have to keep some of these agents in mind. At least what they do, their mechanisms, what they fight against. So omalizumab, you should know that it is an anti-immunoglobulin E agent for MCQ purposes. All right. So now, how about those between 6 to 11 years? All the things we've been doing is 12 years and above. 6 years to 11 years, then below 5 years. What are the options available? So the same thing as we did for 12 years and above, you need to assess, adjust, and review. It's the same thing. But here, you need to take into consideration the age. They are not yet grown, so there are so many things that may be difficult, especially inhaler techniques and all those things. So you need to consider them with that vulnerability, because it is better for an adult to easily understand inhaler techniques as compared to. So in this patient, you should be thinking about additional things that you can do to improve inhaler techniques. For example, the need to use a spacer device and what have you, so that it can abort that tedious step of synchronizing actuation and inhalation when you are using a metered dose inhaler, for example. That is what makes so many people find it difficult to get the technique of inhaler use. The metered dose inhaler at the point where you need to synchronize actuation, that is pressing on the actuator to release the drug and simultaneously inhaling the drug into the airways. So many people can't do 2 things at the same time, and therefore they tend to do one and forget or can't do the other one simultaneously. This age group all the way to lower than 5, Of course, this is an obvious problem that they face. So as part of your review, assessment, and your adjustment, this is very, very important when it comes to pediatric patients with asthma. Adding agents like spacer device to abort that technique of simultaneously actuating the canister and inhaling the agent at the same time. Let's look at the options available. It's not so different from the adults, but let's see. Why is this thing freezing? Okay, all right. Okay, so they also have their recommendations. Oh, okay. So again, they also have their preferred recommendations and other recommendations. So all things being equal, their preferred controller, that is to prevent exacerbations and control asthma. Do not forget your usual reliever therapy that you keep. They are also keeping the same formoterol-based combination for reliever techniques. So at step 1, the preferred technique, they are using low-dose ICS taken whenever SABA is taken. That is their preferred controller therapy. And then the other one is considering daily low-dose ICS. So for those who are between 6 to 11 years, this is the preferred one. And the alternative is to use the low-dose maintenance ICS. Remember, in pedics, we are not using the maintenance dose ICS because we know that corticosteroids can even limit their rate of growth. And therefore, all things being equal, we hope that we use fewer, even when you are using inhalational corticosteroids that will not give a lot of systemic problems. We still hope that we limit the use of corticosteroids in pedics. So that one you have to keep in mind because corticosteroids use may limit the rate that they will develop in terms of growth. So that is why you are seeing low doses and not straight away using the maintenance dose. But if you go to the adult track 1, we were talking about using maintenance dose combination of ICS and formoterol. By here, the PRN is the first option because we wouldn't want to use every day because of fear of stunted growth on continuous use. But if you can't use this option, then you have to come to the other alternative, low dose everyday ICS. The next step is to go to the step 2, which means that the step 1 has failed and you are now going to use a daily, that is the maintenance, a daily low dose inhaled corticosteroids. So you are always using it on BD basis. Remember when we defined low dose, high dose, or standard dose, it was according to age. So you look at the chart and you refer to the type of ICS and the way they have defined the dose according to the age group. The alternative is to do a daily leukotriene receptor antagonist or low dose ICS taken whenever you take a SABA. Please, it is very difficult to commit this into memory, but at least just know the options available. I'm not saying that chew all this. You can't chew the one for adults and the one for 6 to 11 years and even add the one for below 5 years. But at least just know how the things are made, the pros and cons, why we are doing certain things in certain age groups as compared to the others. At least that will help. Then as this step also feels, yeah, hello?
Please, just to clarify, for the children, the ICS they are taking is a SABA 2 included.
Yeah, it depends on the track you are going. You see, we are doing 2 tracks at the same time. This is the first. The top one is the first track, the preferred one for them. And if you can't use it, the lower one is the alternative. Do you get it? So if you
Yes.
are on, if you are on the first track, as in the one preferred, you are using low dose ICS taken whenever SABA is taken, so on PRN basis. And the alternative is to use what? Daily low dose ICS. That is why I explained that this one has become an alternative because we want to limit the use of steroids in PDEX because exposure to steroids can result in stunted growth. Are you okay? Hello?
Docs, is this just
Same.
for the reliever or it's for maintenance and reliever?
No, the reliever is here. See the reliever. The reliever is down there. So the reliever, we are looking at short-acting beta agonist as first line. Or, again, ICS plus formoterol. Here again, the ICS, we don't want to use frequent ICS in PDEX. Are you okay? Please, are you okay?
So it means that the alternative, even though now you are going to do the ICS daily, you still add your SABA to it.
Yes, but the SABA is reserved for breakthrough attacks.
Okay. Thank you.
Are you okay? For the
Yes.
alternative, because that one is only ICS. Only ICS. Okay. Okay, so the step 2, then step 3. So step 3, obviously, you are adding on. You are adding more. It means that step 2 has failed. And you are now doing low dose ICS plus LABA. So, for example, Symbicort can now be used. Or you are using medium dose ICS or very low dose ICS for Metero as maintenance and reliever. Symbicort is always very good because it can do both, for both maintenance and reliever therapy. If the first alternative or the first track is not available, then you move to low dose ICS plus leukotriene receptor antagonist. Then you move to step 4, where you are going to increase the dose from low dose to medium dose SABA. And at this point, if still the patient is not doing well, you need to refer to a respiratory specialist. Always remember that it is at this point, the step 4, that you refer to the respiratory specialist for that person to be doing the most potent but highly toxic agents at this point. So as we did for 12 years and above, a similar thing. You are doing tests for phenotype, atopy, then you are likely going to do higher dose of ICS with LABA, then you'll be adding the biological agents, anti-immunoglobulin E or anti-interleukin-4, whatever. Then the alternative is you using these similar combinations, but unfortunately, you are doing oral corticosteroids in PDEX. It means that is your last line of defense. You know that systemic side effect is going to affect the growth rate of these particular individuals. But it's better you prevent recurrent exacerbations as compared to you thinking about their growth, because that one will kill the person faster. All right. Now, how about those who are 5 years or younger?
Doc,
5 years. Yeah, hello.
so you said for the previous slide, so are you trying to say that we can use a Symbicort in a child between the ages of 6 and 11?
Sure. That is the recommendation, but it's not first line. It's not first
Obviously, so
line,
the
even if you are,
SABA.
yes. So as needed, short acting agent. And if that is not applicable, then you may go for ICS for Metero as a
But say,
reliever when you are doing. Yeah.
but Doc, the previously, I think you said we are not supposed to use SABA alone.
No, this is for reliever.
Oh, okay. Thank you.
See, can you see reliever here?
Yes, please.
It's for reliever therapy. Okay. All right.
Hello, Doc. Could you kindly go over step 2 for the children
Yes, sir.
6 to 11 years.
Hello?
Hello, Doc. Yes,
Yeah,
could you
hello.
go over step 2 for the children 6 to 11 years?
So step 2. Okay. So step 2, you are using yeah, so you are using daily low dose inhaled corticosteroids daily. So that's the maintenance, but low dose. It means BD basis. Or the other alternative, that is if this is not available or is not applicable, then you are doing daily leukotriene receptor antagonist or low dose ICS taken whenever SABA is taken. That is on PRN basis. That is the step 2.
Okay. So, Doc, why is it that the step
For
2,
6 to 11 years. Are you okay?
I have a question. Step 2, the other recommendation, it seems to align with the primary recommendation under step 1. That's the low dose ICS whenever SABA is taken. So I'd want to ask why that is so, because I don't seem to understand it. If
You see, it's all about safety. You see that thing, and the efficacy, the evidence on efficacy. So the tracks that they are mentioning, the key thing is, do they have evidence on safety and efficacy? Are you okay?
Yes.
That is how they go about it. So if it has been proven that, for all the options available, that is how best you can do it, then you start. You straight away, you give your best shot according to the patient presentations. Are you okay?
Yes.
Because the daily control obviously is better. It's better, but in PDX, you are also thinking about safety issues.
Okay.
So you are thinking about safety because you don't want to, as in, punish somebody from not getting to his usual growth height because of asthma. But when you can't, as in, control it, then you don't have any option because the asthma will kill the patient. So just do what you got to do. And do it. So always at the beginning, you try and then balance between efficacy and safety. But as it gets worse, then Masa, you do what you need to do. All right.
Okay.
So quickly, let's look at. Yeah. Hello.
Just a quick one. So I get the first step with the safety and efficacy, hence the low dose PRN. But usually in the second step, wouldn't the patient experience more symptoms as like compared to step 1?
Yes.
So
that
the
is the
person
issue.
is using, if the person is using, let's say the daily low dose ICS, the BD dose didn't work for the step 2. And let's say you have to switch to the low dose ICS taken whenever SABA is taken. In a patient with increased symptoms, that will possibly mean that the person may take more ICS doses than someone in the step 1.
Yes, it's possible. So that's why it's always the alternate therapy. You get it? As the disadvantage increases, then they push it to the latter.
Okay.
Are you okay?
Yes.
All right.
Okay. Thank you.
Okay. All right. So quickly, let's go to. So please. I hope you try to understand the exams. Normally, they would bring cases if it will be on asthma, normally adult ones. And normally in exams, they prefer doing mostly acute attacks. Then they ask you to do your own maintenance therapy. So now that you know the advantages, combination of ICS and formoterol and those things, you just know that, okay, all things being equal, this is what you are doing. If you are recommending any ICS frequent use in PDX, then you should know a better alternative. All right. So those below 5 years, of course, you also do the assessment. they share similar issues with those below 11 years in terms of inhaler techniques, and therefore you should make sure that you protect them. So what are the options available? What are the options? So first track or first line, you need to consider intermittent shocked ICS at onset of viral illness. These individuals, their immunity is not yet developed, and they are always at increased risks of viral infections. Remember, infections are very strong trigger factors when it comes to asthma. So you need to always make sure that you prevent the infections, immunize them against all the possible viruses, and you make sure that when it happens, the preferred one in terms of safety and efficacy. Obviously, these individuals are even at risk of corticosteroids, more than even those between 6 to 11 years. But we still need to control the asthma. So you consider intermittent short courses of ICS at the onset of the viral infections. And always their reliever therapy is as needed short-acting beta agonists. You see, because of their age, we are not even considering formoterol combinations with ICS. We are looking at only SABA. We want to limit the use of corticosteroids in these patients as far as possible. And then consider infrequent viral reason and no other viral infections, then you have to consider using the reliever all the time. Step 2, that is if they are not doing well on step 1, then of course you are increasing, either adding on or you are increasing the doses. So daily, it becomes daily low dose maintenance corticosteroids, which we don't want, but we don't have any option. Or you do your daily leukotriene receptor antagonists or intermittent short course of ICS at the onset of respiratory illness. If still they are not doing well, remember normally the assessment is done on 3 months. That is if they are controlled and you consider stepping down to the next lowest or the next lower step. So if you assess and they are doing well, you come back to step 1. If they are not doing well, you are moving to step 3, where you'll be using double dose or double low dose ICS. It means that you are increasing the doses of the ICS, not a good sign, not a good sign at all. Able to control, you refer. So it is the respiratory specialist who will be doing step 4, since they are so vulnerable and they don't have any step 5. So you refer to step 4. So at this point, it is the specialist who will control. Remember, the biologicals are very potent and do have very serious side effects. And therefore, giving this to somebody below 5 years, you need somebody with the expertise. You don't hand it over to somebody who is a general practitioner. And therefore, at step 3, you are what? Moving the patient to a respiratory specialist to continue and manage these individuals. So that is one big difference between those below 5 years. They don't have any step 5. So at step 4, you refer. From 6 years going, you refer at step 4 because they have step 5, which will be taken care of by the respiratory specialist. Now, when do you step down? As I said, when you are able to achieve control at a certain step for 3 months, then you can consider stepping down. But you don't just step down, because if you step down at a time where the patient is at increased risk of exacerbations, then the patient may get breakthrough attacks. And therefore, you choose the appropriate time to step down. So, for example, at the time that the patient is not having any respiratory infections, the person is not traveling, because change in environment, you never know where you are going, the kind of trigger factor that you can face, especially in Ghana where we have a lot of bad roads. You are traveling, then you get to an untarred road and you have a lot of dust. And at that time, if you have stepped down, you may be in trouble. Pregnancy causes a lot of problems, a whole lot of unstable situations. So do not step down when the person is pregnant. So you step down at 3 months and you do a therapeutic trial. So that is the approach. So you just step down and you monitor the patient closely and see if the person will be okay on the level that you step down to. So you'll be monitoring the patient with signs and symptoms. You use the lung function test, whether the patient will do well or not. Mostly, when somebody is on ICS, you can step down by doing lower than 20 to 50% at that 3 months. So stepping down is going down the current dose, reducing it by 25 to 50%. Normally, it will be okay for most individuals. At the moment you step down and there is any breakthrough attacks, quickly get back to the previous level. So if the patient is on step 3, you step down to 2 and it doesn't hold, please quickly go back to step 3 to maintain and then find another time to do so. Now, poor medication adherence. What are some of the contributing factors and how you, the clinician or the staff, healthcare giver, how are you going to identify some of these cases? So factors contributing to poor adherence. At times, it may be due to the medication or the regimen factors. For example, a person may find it difficult to use a certain inhaler device. Maybe the person is having arthritis of the hand. For example, rheumatoid arthritis, and therefore the hand is always stiff, very painful, and he can't operate the inhaler device. Then that will make it very difficult for the person to get better control. If the regimen is burdensome, take this morning, take this afternoon, take this evening, you confuse the patient and it doesn't motivate the patient to do it. If you are using different inhalers, you are using metered dose inhaler at the same time you are using a discus or a tubular inhaler. These two, they have different techniques. The patient gets confused and doesn't get proper use and therefore not proper control. At times too, the poor adherence may not be intentional. So unintentional poor adherence. Genuinely, the person might not understand the instructions. But maybe because of fear, maybe you are shouting at the patient, you are intimidating the patient. So the patient is unable to express his or her views and thought. And therefore, everything that you say, he will not. Okay, I understand. Meanwhile, genuinely, the patient does not understand the instructions that you are giving. Some individuals too, like adults, they are always hot and they have a lot of forgetfulness. So they may skip their doses. And normally, because of daily routines, they are not using it. Maybe it's on PRN, or maybe they forget to use their drug as they are supposed to. Maybe it is BD. In the morning, they are hot, they are late. They skip it and run away to work. When they get to the workplace, they realize, hey, I did not take my ICS. These are some of the things. At times too, because of costs, genuinely the person cannot buy the type of medicine. Symbicort, Seretide, all of them are above 100 cedis. And if the person cannot afford, then it's a genuine case. Then additional stuff includes the intentional, as in factors. It's intentional. The person knows what he's doing. He just don't want to use the medication. So at times it's because of perceptions, like, is it even necessary for me to treat asthma? Me, I don't have asthma. It's not necessary for me to treat. They are also in a denial, or they are angry at the whole case. Why me? At times too, they have inappropriate expectations. They expect that the moment they use the drug, it cures the condition. Meanwhile, asthma is chronic, and therefore they get disappointed and decide not to use it anymore. Others too are concerned about side effects of the drugs. Others think that when they are seen using the inhalers, people will talk about them. So stigmatization is also an issue. To others, their religious beliefs and cultural beliefs, there is no room for any drug therapy when it comes to asthma, and therefore they won't accept to use. So you as a health caregiver, how do you identify these factors and fix them? How do you? So when you meet them, they are saying that is for them, you understand them. So acknowledge the likelihood of, as in why they are not doing the adherence. You have to fish for that information. You as the expert, you know how to ask your questions and then find out some of these factors as to why they are doing it. Always, all the time, you need to check the medication usage. So most of these machines will have counters like Symbicort and Seretide. They have counters. So as the doses, or you keep on using the drugs, then the doses decreases. At least you can use that as a guide to know whether the person is using the drug or not. The last date that they were prescribed with controllers, as against the time that they are reporting. Do you expect the controller to have been exhausted, but they still have it intact? I can tell you that they are not using the drug at all. And then, how often do you dispense these medicines? Do they even come to the hospital for review or not? Are they supposed to be there every 3 months and they are coming at 6 months? All these can help you gather information on the medication usage. Any queries? Last Captain, any queries?
No, please.
All right. So now, what are then the strategies? The strategies. Because you see, inhaler technique is a problem. And so we are always concerned about inhaler technique when it comes to asthma. So the strategies to ensure effective use of inhaler techniques. Choose. How do you choose the type of inhaler device? Because you are not the person going to use it. It is the patient who is going to use a certain type of inhaler. So you choose according to the patient's capabilities, the inhalers or the device that the patient can manipulate, the patient can operate. So it is very important. If you decide and choose a certain device that I can't use, then it's more or less like you haven't even given me anything. Because if I get to the house, I'm unable to operate the machine. So appropriate inhaler device, patient skills, and of course, the cost. If I can't buy, I can't have the drug and use it. If there are any physical barriers that will prevent the patient from operating the device, note that and choose the appropriate option for the patient. And especially when you are using different types of inhalers at the same time, you confuse the person. One is breath actuated, one is metered dose, different strategies, and even one I'm unable to use it, and you are giving me multiples, then confusion, I can't use it. Then always check at every opportunity, any time that you get to meet any asthmatic patient comes to you for dispensing. Don't just pack the devices and hand it over to them, thinking that they know. No. Inhaler technique is always a problem. So always check at every opportunity, check. And of course, ask the patient to demonstrate the inhaler technique to you. Try and identify any errors during the demonstration and correct them. And again, let the patient repeat as a way of confirmation that now the patient has the technique. This is very, very important. Now, what are the types of the inhalers that we are talking about? So common ones include the metered dose inhaler. Salbutamol inhaler is a typical example where you press a certain actuator and it releases the drug, then it comes. Then we have the types that you don't need to press anything. You release the dose with a very deep breath. So like Seretide, like Symbicort. These inhalers, tubal inhaler in Symbicort and Discus, that's the disc-shaped one, the violet or the mauve one. In both situations, you don't press anything to release the drug, but you release the drug with a very forceful breathe-ins. And in this, you can have it as either a soft mist or a dry powder inhalant. It depends on the drug in there. Last Captain, remember last week, I advised or recommended that you should learn or read on the systematic way when it comes to inhaler technique, because you are going to take over. If I say you, I mean the class, because I know you dispense a lot of inhalers. And therefore, I expect that you are on top of issues when it comes to the inhaler technique. Have you done that, class captain?
Yes, please.
Okay. So I'll start from you. Can you take us through metered dose inhaler?
Okay, so
let's see, first time the device is new, you are now going to use it. How do you teach your client?
Okay. So for the metered dose inhaler, it comes with, like, it's a canister, obviously. So it has a cap, and then it has the parts that the drug is in, which is inside, and on top of that, that's where you press. So for a patient who is now going to use it, you have to prime the inhaler. So first and foremost, you show the patients the different parts of the inhaler and where the drug is supposed to come out from. And then you tell the patients to shake, always shake before use to, I don't know, shake the drug here to make the particles or the drug to disperse the particles. Yes. So the patient will take off the cap and then prime. So the priming is meant to let the actual dose, like the dose desired, be dispensed. Like when the patient puts it, is about to like administer it. Yeah, it's about to take it in. Yes. Pardon me. So you shake first, you take off the cap, and then you breathe out as much as you can.
Okay,
And
so
then
please hold on. So one additional as in purpose for the priming is to confirm that the machine is working well. The machine is on point and is not faulty and it's able to release the dose. Okay, continue.
Okay. So when you take out a deep breath, then you put your mouth on the mouthpiece. You make sure that your mouth has your lips have completely covered that part. So as the slides are saying, it has to form a good seal. Then you breathe out slowly, as already stated. And then at the same time that you are breathing in is when you press the actuator, and then you hold your breath for about 10 seconds.
Okay, and so hold on. So this is the point that is very difficult for most individuals. Doing two things at the same time. The point of actuation and breathing synchronization. very, very difficult, and most people are unable to do this step, and it causes a lot of, as in, errors when it comes to inhaler technique. All right, please continue.
Okay. So as you okay, I was speaking about it. So as you like breathe in is when you press the actuator, and then you hold your breath for 10 seconds. The drug would have entered the lungs, and then you breathe out slowly after that, and then that's the end.
Okay, so when you are taking the drug in, you breathe in through your mouth, but at the end of the technique, when you are breathing out, you breathe out through your nose. Always make sure that you don't breathe directly on the device. Don't breathe out on the device and get moisture and those away from the device. All right. So what if I want to take a second? Because, for example, for salbutamol inhaler, one puff is equivalent to 100 micrograms. So maybe in a mild or moderate acute attack, I do one puff and I'm not feeling well. It's not okay for me, and I want to take a second puff. What are the recommendations? Because this is just one cycle and I have one dose. So when I take the second dose, at what time interval between the first one?
So you can wait for about a minute before you take the second dose.
Yeah. So normally 30 seconds to 1 minute, so that the whole machine, the whole setup can reset. If not, it normally happens during an acute attack. You see somebody continuously pressing the actuator, the person doesn't know the inhaler technique. You need to allow the machine to set, and it needs at least 30 seconds to what? Set. Then you can repeat from step 3. So don't keep on pressing it like every 5 seconds. The drug will not come out. You'll be releasing only the carrier gas with little to no salbutamol coming in. The drug set at least 30 seconds after you have used the machine. Okay. All right. Thank you very much. Class captain. So choose another person to do the discuss, the Akuhela, like Seritide. You can see this person holding Seritide. I'm sure this is Seritide. And then order to deal with, right? And how do we do it? Class captain, please give me one person.
Abner, please help us.
So I just go for my Seritide today. How do I use it?
Abner, please help us.
Okay. Hello.
So you are supposed to add all the advices that you give after using the device. Okay. Abina, please, are you around?
Yes, sir.
Okay. Can
Okay,
you please
so
take us through?
all right, so for the discuss, what you do first is that you open the cover, but then as you are doing that, to be prepared to like exhale fully, and mostly you advise your patient to try to bring out all the air in their lungs as they take in a deep breath and they exhale out with like force. they exhale out fully to empty the lungs so that the drug can easily enter when they suck it in, like breathe it in.
A very, very, very good point. Very, very, very good point. Because you are going to put in an external gas, you need to prepare, make room for it. Okay, continue.
Okay, so as you slide open the cover, you need to be sure that everything is intact. That's when you check the portion where the various doses are, that it's not closer to the zero, that there's still enough in there when you look at the counting. Then when you are done, you hold the discus in a horizontal position. That's is like okay, as shown in the picture. Yes, so that it's much easier to suck it in when you are breathing in. Then as you hold it in that position, you need to breathe out. So as I explained earlier, how you go about the breathing in and then the breathing out. Then to load the dose, you need to, there's a lever on the side of it. So you push it backward with your thumb and then it comes back up again. So you hear like a click sound. The click sound is similar to what you hear when you're using the Symbicort. Yeah. So afterwards, you can either sit or stand, but you should be in a comfortable position to be able to take in the drug. So when you are done, you bring it up, as I said, in the horizontal position to your mouth level. Then you breathe out, as say explained, away from the inhaler. But when you are breathing in, you bring the inhaler closer towards your mouth.
Hello?
Hello, say.
Yeah, please continue.
Okay. So I was saying that you breathe out away. So that means if you are breathing out, you push the inhaler away from your mouth, let's say to the side. Then now when you are ready to breathe in, you bring it back again. Then you take, like, you sort of breathe in it like in a sucking motion to like force the contents straight into your lungs and such that it doesn't settle in your mouth or anywhere. So yeah, but while you're doing that, you place your lips firmly around the mouthpiece of the discus so that none of the drug particles like moves into the atmosphere, but then everything gets into your lungs. So when you're done, then you can now wait for the 10 seconds counting. Not all patients can do the 10 seconds counting, but we try and encourage the patient to go close to that 10 seconds count. So they can do it with their fingers, like 1, 2, 3, 4, 5 years. Then when they are done, and they close it and that's it.
Remember, I told you this device will contain a corticosteroid.
Oh, yeah, so they'll raise their mouth with
So
water.
do not forget to add your camphor. So it's not only your mouth, your oropharynx too. You rinse it with water anytime that you use this device. Why are you doing that?
To prevent oral thrush from occurring.
Okay, so oral thrush and what? It's not only oral thrush. So in other words, what are the side effects of inhalational corticosteroids? Oropharyngeal candidiasis, also known as oral thrush, is one. And what else?
Hoarse voice.
Hoarseness of voice. So you are not going to have nice voice anymore. So to avoid this, you are advised to rinse your mouth and in general the oropharynx with water whenever you use the device and you spit it out. This will minimize your chances of getting this problem. One key thing that the two of you've missed is after putting or placing the machine in your mouth, make sure that you have your tongue on the floor of your mouth. Do not raise your tongue. If you raise your tongue, it will cover the opening where the drug will be released. So people do that. They will put the machine in their mouth and to is raised, blocking the route where the drug will release. So make sure that you have your tongue on the floor so that they will have a clear way for the drug to penetrate through your mouth and enter your airways. Okay, class captain, give me another person to deal with Symbicort type to Brohela. Symbicort.
Please help us.
Some of these things, when you go for oral exams, they can easily ask you to take them through. And it's supposed to be stepwise as you are doing. Stepwise approach when it comes to inhaler technique. As captain, if Amakwan is not around, please mention another person.
Sandra, please help us.
You don't have a male friend. You're only mentioning female.
Matthias, please help us.
Or you add it, class captain.
Kelvin, please help us.
Class captain, take us through what you see on the slides.
Okay, so for the Tebuhaler, so an example is the Symbicort. So the first step is to unscrew and remove the cover. So this one has a dose counter, so it shows you the amount of drug you have left in there, or the number of doses you have left in there. So you make sure that
So
it's
let me hit on the dose counter. The dose counter doesn't reduce like in units. Let's say if you have 120, you use it, then it goes to 119, 118. No. It will either be recorded in 10 units or at times even in 20 unit intervals. So if you are at 120, you use it, you will not see it reducing to 119. But as you keep on using it, then a time will come where it will show from 120 to say 110 or 100. So at times you use it several times and you still have the 120 on it, only for it to reduce drastically to say 100 from 120. That is how the reduction goes. It doesn't go per unit. Like any time that you use it, then you see that it has reduced by 1 unit. So take that and explain to the patient. Because when it gets to 20, if it reduces by 20 units, if it gets to 20, it won't show you that it has now reached 19, 10, 9, 8. And therefore, by 20, you should get ready to buy another one or go for your review. Else, you'll be surprised. It may get to 0 where you are not even aware.
For this one, you have to keep the inhaler upright. So it has something that you twist at the base. Okay, so you're supposed to twist it around like in one way and then the opposite way till you hear a click. So like clockwise and then anti-clockwise, and then you hear a click. Then the next step is to
So what does that signify when you hear that click? It means that the dose has been loaded. It means the dose that you are about to take has been loaded. Okay, continue.
Okay, so for this one, you have to okay, like the previous one we spoke about, you breathe out gently away from the inhaler. So you empty your lungs, and then you form a close, like a tight grip, like your lips should seal the mouthpiece. And like Doc said, make sure that your airway is clear, like make sure your tongue is not covering it. Okay. So you breathe in strongly and deeply, because that's what will pull the drug from the tubular into your lungs. So after you breathe in strongly and deeply, then you remove the inhaler from your mouth, and then you hold your breath for the same 10 seconds, or as long as you are comfortable. And then you breathe out gently away from the inhaler. And then if more than one dose is needed, you repeat all the previous steps. So then you replace the cover, and then you rinse the mouth with water because it contains the steroid.
All right. Thank you very much. So please note the various types of inhalers, the breath actuated ones and the metered dose inhalers, and know how you will take your patient through. This is very, very important. Now, in certain situations like acute situations, you will need high doses of most of these agents, especially the short-acting agents that are used as relievers. And therefore, the metered dose inhaler, for example, is unable to give you these high doses, like 5 milligram and those things. They deliver in 100 micrograms. So even when you do 10 puffs, you've done just 1 milligram. That is 1,000 micrograms. In that case, nebulizers will do the trick. So in cases where you need high doses, nebulizers are the agent or the technique. Nebulization is the technique that you use. And normally, the nebulization makes it easy to deliver the drug. It doesn't actually demand any skill from the patient, as you have systems in place to drive the content into the patient's lungs, and therefore it is preferred in severe acute situations where the patient is in distress and can't actually do so many things. So the nebulizer normally will release the drug. You normally put your drug in it as or in the form of a liquid. And of course, the machine will turn the liquid into a gaseous substance. So it will vaporize. It will vaporize your liquid preparation like salbutamol that you put into the machine into a gas. And it is always connected to a carrier gas, for example, oxygen, to help carry the vaporized active ingredient to the patient. So the oxygen here will be serving two purposes. One, as a carrier gas, and two, as an agent to go help solve hypoxemia. So it is very important to note this. The agents are placed in the machine in the form of liquid, and the liquid will be vaporized into a gas. Normally, the droplets that are produced are very tiny and about the size of 5 micrometer in diameter. That is how the droplets are turned to. So converting the liquid to the gas gives you very small, tiny droplets that can easily be inhaled. Now, as I said, the nebulization requires little to no effort from the patient, as in coordination, because you have the system in place that will drive the machine. If you are using any agent that can cause trouble to the eyes of the patient, for example, then you have to use face mask, or you can even attach a mouthpiece to the device so that it avoids this. So normally, what normally cause problems in certain patients, for example, patients with glaucoma, and you are doing an anti-muscarinic agent, antimuscarinic agent will precipitate glaucoma, and therefore you wouldn't want some of the vapor to get into the eyes of the patient, and therefore you need to cover with some face mask so that the vaporized antimuscarinic agent like ipratropium will not get into the eyes and worsen the whole situation. Nebulizers has its own disadvantages too, as well as advantages. So few advantages: no coordination is required. All age groups can use the drug, and it is very good when it comes to severe attacks because you need little to no coordination from the patient who may be in a distress at this point. Disadvantages is that it's expensive. It's expensive and it creates a lot of noise too. The vaporizer creates a lot of noise and it's cumbersome to set it up, and therefore you need a well-trained individuals at times to do it. And of course, you need to calculate your doses because the drug is coming in a liquid preparation. So if you are not that good, you can't do your calculations to know the exact dose that you should put in there. Now, how do you care for nebulizers? How do you care for nebulizers? Most nebulizers, the chamber where you put your drug and it is vaporized, you can use it for about 3 to 4 months. If you are using it on personal basis, you use it for 3 to 4 months and you can't dispose it off. And all the time when you use it, of course, there will be some residues. You can't, as in, vaporize everything that you put there. There are always residual quantities that is left. So as part of the care for your nebulizers, you must always make sure that you disassemble the whole setup and empty each time that you use the drug. Rinse the chamber in the hot water and then dry by blowing hot air, by blowing air through the device. And then normally there is a recommendation that if you don't disinfect the system, you may have some bacterial growth and other microbial growth in it. That could even be a source of infection, especially in the hospital setting where it's not for private use. Everybody will come and use it. So it is advised that you treat the system with agents like 0.02% hypochlorite to prevent bacterial growth. At least you can do that every once a week. And then afterwards, the chamber is then thoroughly rinsed to remove all traces of the hypochlorite and you dry. Try and then make experts come in and service the machine at least once a year. Even if it's not spoiled, they should come and then just have a look at it and see if it is actually working. Spacer device. Class captain.
Doc.
What are the advantages of using spacer device? Spacer device are attached to inhalers, like the metered dose inhalers. And they have some special advantages. What are some of the advantages?
Okay, so it ensures that the dose that you want to get into the system of the patient is actually like achieved. It is particularly useful for children because sometimes they find it difficult to properly use the inhaler.
Okay. Yes, very good. And again, this spacer device can also help reduce the risk of getting the side effect of particularly inhalational corticosteroids. So the oropharyngeal candidiasis and the hoarseness of voice, if you use a spacer device, it drives the content or the drug above. It's like it jumps the drug above there, and therefore you get limited contact of these areas with the drug. Therefore, the patient tend to get little chance of getting these side effects of inhalational corticosteroids. Please, if you are asked to state the side effect of inhalational corticosteroids, forget about the systemic side effect of steroids. If you add those things, you may get it wrong. That is not to say that inhalational corticosteroids may not or can never give you systemic side effect. But typical of exam setting, when they ask you for the side effect of inhalational corticosteroids, they are actually looking for the local side effect, oropharyngeal candidiasis, and hoarseness of voice. So please stick to that. So that is the spacer device. This is how it looks like, plastic in nature, which is attached to the mouthpiece of inhalers like the metered dose inhalers. One good thing is that in individuals who are unable to synchronize actuation and inhalation, if you use a spacer device, you don't need to observe that action. You just actuate into the spacer device, you take your time and breathe slowly from the spacer. And therefore, there is no need to worry about that step that is very difficult for most individuals to do. That is one strategy. As you said, it also makes sure that the required dose is delivered into the airways as we wish. So these are all advantages of spacer devices. Now, yes, so you just remove the mouthpiece and then you fix it. Make sure that it is horizontal. You wrap your mouth now around the spacer device, not the mouthpiece, because the mouthpiece has been connected to the spacer device. So as the spacer is horizontal, your metered dose inhaler will be vertical. So you actuate into the spacer, then you breathe. Always make sure that you have created a very good seal around the spacer so that you don't get some of the drugs escaping. Then you breathe gently from the spacer and you hold your breath again for about 10 seconds. As the second lady said, you may not be able to do the 10 seconds, but at least any period between 5 to 10 seconds, using your fingers to count, almost like the way the second sticks, is okay. This makes sure that the drug penetrates deeply into the lungs and what have you. Okay, so how do we care for our spacer device too? So spacers, of course, are supposed to be washed regularly in warm soapy water, and do not rinse them, as in do not use any cloth or cotton to try and then wipe the droplets of water. Make sure that if you do that, it will affect the anti-static coating. And therefore, henceforth, if you actuate into the spacer, the drug may get stuck onto the walls of the spacer instead of allowing it to flow through. So do not use it. All spacers should be replaced every 6 to 12 months. For pedics, you may add a face mask to avoid the drug getting into their eyes. Now, asthma action plan. Action plan is all the input, all the strategies, all the things that
Sir, please, quick question.
Okay.
Please, can you please comment on the water test that is used in checking if the canister of the metered dose inhaler is empty?
What I'm not aware of that. If it's empty, then you do water test. Any idea about that?
So I was hearing that you get a bowl and fill it with water and you place the canister in the water. But I wanted to know if it was very efficient or
looking for bubbles or what?
No, they are saying if it is full, if it's a full canister, it will sink in the water. But if it is half, then it will be inclined at an angle. If it is empty, it will be horizontal. Something like that.
So why would you do that? Maybe at the point where you, as in, when you have, as in, acquired a thing, you are testing to know whether it is full or half so that you return, or
As in,
why are you doing that?
if the person is using the drug and wants to know if he's close to finishing or not. So I wanted to know if the test is effective and if he
Well,
should be
I'm
added
not
to the
I'm
counseling.
not sure about this, but I don't know as to the point where even dipping this in the water can even affect the performance of the machine. I don't know about this test, but
Okay.
I think maybe the weight alone, as you use it, you realize that the weight will be reducing. Once you handle the drug, the weight will be reducing, and then it's unfortunate that most of these MDIs don't have counters.
Yes,
It's
please.
true, but I would prefer using the weight as you use it, as it's getting closer to as in finishing. Obviously, the weight will be reducing. It will never be the same. I don't know about this water test. You depend the whole system water just to test whether it is finishing or not. I don't know about this test. But let's read on it, and as in weigh the how applicable this is. Dipping the machine in the water just to test whether it's finishing or not. All right.
Yes, please.
So
Thank
back to action plan. Back to action plan. So all the strategies that you put in place, try to identify possible trigger factors, all the possible reasons as to why you are not, as in, getting proper control when it comes to somebody's asthma, including the healthcare team, the patient, and caregivers, if necessary, or relatives. This is what we refer to as asthma action plan. So, for example, if somebody presents with an attack, as part of the action plan, you would want to identify reasons for that attack. Is it because the patient is not being adherent? Is it because the prescription, even the doses, were not on point? The patient is due to be graduated from, let's say, step 2 to 3, and the patient is still on 2. Is it because the patient doesn't know his or her inhaler techniques? Is it because the patient did not even buy the drug? Is it because of an exposure to a trigger factor? Is there any underlying infections? All those things that you do to find out possible causes and developing solutions to those problems is what we refer to as asthma action plan. And this must be a written document, not verbal. So all the things that you identify and the solutions, the strategies to solve all those things, you write them down and then hand it over to the patient. This is what we call asthma action plan. So everything involved in trying to identify treatments. Now, we are almost done, but quite recently we had this problem, COVID-19 and asthma. And then since they are both respiratory problems, then there are several concerns that, so then if you have asthma and you get COVID-19 in addition, then what happens? Are there any risk when it comes to you being an asthmatic? Are you at an increased risk of getting COVID-19? And when you get it, what is your risk of dying from COVID-19 with asthma? So many questions people started raising. In fact, those with asthma were very, very afraid. I remember my boss at that time was an asthmatic, and he wouldn't even want to come to work because he was afraid that with his asthma, if he gets COVID, then that will be, or that may be, his end. So he stayed home all through, and we had to cover him for that long. So the question is, are people with asthma at increased risk of COVID-19 or even getting severe COVID-19? So what does the evidence state? People with asthma do not appear to be at increased risk of acquiring COVID-19. So that is the evidence. And then systematic reviews have not shown an increased risk of severe COVID-19. In people with This is where the thing comes from. In people with well-controlled or mild to moderate asthma. So the fact that you have asthma doesn't put you at an increased risk, especially when yours is well-controlled or is mild to moderate. So that is the answer to that question. Are people with asthma at increased risk of COVID-19 or the severe type? The next question, are people with asthma at increased risk of COVID-19 related deaths? Overall, the evidence indicates that people with well-controlled asthma are not increased risk of COVID-19-related deaths. They are at increased risk. And even in one meta-analysis, just one, mortality appeared to be lower than in people without asthma. However, the risk of COVID-19-related death increased in people who had recently needed oral corticosteroids for their asthma. Remember, by the time you would need oral corticosteroids, then it is either you are suffering from acute asthma, where oral corticosteroids may be used, or in chronic management, we have exhausted all the initial steps, and we are at the level where we don't have any choice than to use oral corticosteroids. So this relates to the severity of your asthma. As for these two, if you are in acute attack or yours is the severe type of asthma, then of course, it will increase your chances of suffering from COVID-19 related deaths. That one is true. And the next question is, what are the implications for asthma management then? So it is important to continue good asthma management with strategies to maintain good symptoms control, reduce the risk of severe exacerbations, and minimize the need for oral corticosteroids. Because once your demand for oral corticosteroids increases, it means that you are having severity. And severe asthma with COVID-19, you are not going to be happy with that. Now, have there been more asthma exacerbations during the COVID-19 pandemic? So many countries, so the answer is no. The answer is no. So interestingly, we did not have increased exacerbations during the COVID-19. So the answer is no. And interestingly, this answer being no was attributed to the public health interventions. Those social distancing and washing of hands and those things was reducing a lot of instances when it comes to infections and hygiene issues. And therefore, these were the contributing factors as to why individuals with asthma were not having exacerbations during the COVID-19 era. So these are very legitimate questions, and the answers are those that you are seeing. So now, advise patients to continue taking their prescribed asthma medications. Very, very important, particularly the ICS, inhaled corticosteroids. For patients with the severe type of asthma, of course, as it progresses, it becomes severe. If you are on biological therapy, please continue to take it. And if you are on oral corticosteroids, continue to take it so that you minimize the inflammation. Not to forget that by the time it reaches here, then your chances of the negative outcomes increases. And then are inhaled corticosteroids protective in COVID-19? So just one study that they did, they realized that hospitalized patients and the age group was 50 and above with COVID-19. ICS use in those with asthma was associated with lower mortality than in patients without an underlying respiratory conditions. Make sure that all patients have a written asthma action plan, advising them to do all the do's and the don'ts. When COVID-19 is confirmed or or suspected, that risk is moderate or high. Avoid nebulizers where possible, because you see the hospital not for private use. And if I come and use it, it is possible that I might transfer some infectious agent to it. And if not well treated, a second person comes, and during that COVID time, the person can get even COVID-19 from it. So the advice was to limit the use of nebulizers, the ones that are used in the hospitals around that time. If possible, you buy your own nebulizer and use it. All right. Pharmacists, what can we do? What can we do when it comes to asthma? So we can take part in health promotion programs. Of course, we are good communicators. Class captain,
Doc.
what are the attributes of an 8-star pharmacist? You say pharmacist, you are an 8-star. Previously, it used to be 7-star pharmacist. I'm sure very soon they will say 12-star, 15-star pharmacist. Can you mention? I remember this question when I saw communication. So what are the attributes? Anybody with the attributes of an 8-star pharmacist? Before you call yourself an 8-star pharmacist, or your friends start flowing you funds that you are an 8-star pharmacist. At least you can mention all the 8. Mention some. What are some of your attributes?
Must be a good communicator.
So a communicator. Very well. What else? Hello? Hello?
Must be
Anybody? A lifelong what?
Learner.
So you are always going to learn. You are always going to learn. Even on your sick bed, you are going to learn as a pharmacist. What else? Let's mention some few. Up to 5, it's okay. If you're always a teacher, right? You're a decision maker, of course. You're a teacher, you're a leader, you're a manager, you're a team player. So all these are attributes of an A-star pharmacist. And of course, you must apply at least one of it, communication skills, for health promotion. Then you help patients, or for example, in children or the elderly, they are caregivers to identify possible trick factors. That is very, very important so that they stay away from it. Then help identify right inhalers according to the patient in question. And then, of course, counsel them on inhaler technique, very important. And then medication adherence counseling is very good, and monitoring. Making the drugs available too is very, very important. All right. Any question? If not, then this will be the end of our asthma class. Class captain, any question? Any member of the team, any question? Any concerns? If not, class captain, any announcement?
No, please.
All right. Okay. So have I sent these slides to you?
No, please.
Oh.
So please, while you're sending the slide, can you add a case study to it?
Oh, okay. All right. Then I'll have to go to the pool and then get you some asthma case studies. All right. I'll send you some case studies. And
thank you.
but we have more time, so I'm planning about after your exam. The law ethics policy will not take much time. You may finish it within a month or 1.5 months, maximum 2. Then we can start answering questions. That is the strategy. But all the same, I will send you some questions so that you begin to try your hands on. So I'll try and then gather the topics that we've done so far. Almost all the topics. But before I even try and then use this book, Drug in Use. I don't know if you have it. Do you have Drug in Use? Hello?
No, please. No, please.
Do you have the folder? There's supposed to be a folder with most of the document, past questions and everything. Do you have?
No, sir.
Okay, don't worry. So I will send you Drug in Use and Pharmacy case studies. So those books do have a lot of case studies in them, and they've been solved. But I would advise that you first try and then solve the case studies yourself, and you compare your answers to the answers in those books, and then you mark yourself. Are you okay? Don't straight away go and look at their answers. At least the topics that you've treated, you can test yourself by answering all the questions under the cases. And then afterwards, you compare your answers to the answers and see how well you are doing. All right. Okay. So next week. Thank you very
Yes,
much.
thank you. Have a nice day.
Thank you.
Okay.